to today's symposium entitled Technologic Innovations for the Prevention of Catheter-Related Bloodstream Infection, sponsored by Teleflex Incorporated, being presented today by Dr. Mark Rupp. Dr. Rupp is an Associate Medical Director of the Nebraska ICAP and ASAP and is the Professor and Chief of the Division of Infectious Diseases in the Department of Internal Medicine at the University of Nebraska Medical Center. He is the Medical Director of the Nebraska Medicine Department of Infection Control and Epidemiology. Dr. Rupp received his medical degree from Baylor College of Medicine, Houston, Texas, and holds his BS in Chemical Engineering from the University of Texas, Austin. He underwent internship and residency training in internal medicine and completed fellowship training in infectious diseases at Virginia Commonwealth University. Dr. Rupp is a fellow of the American College of Physicians, the Infectious Diseases Society of America, and the Society for Healthcare and Epidemiology of America. He is also the past president for the Society for Healthcare and Epidemiology and is the past president of the ASM Division L for Infection Control and Epidemiology. Dr. Rupp has also served as a consultant for the Food and Drug Administration, as well as the Centers for Disease Control, the NIH, and the VA. Dr. Rupp has published over 400 articles, chapters, and abstracts. He frequently presents papers and national and international meetings, serves as a guest lecturer, and is an active teacher and researcher today. Dr. Rupp's research interests are in the areas of staphylococcal diseases, healthcare-associated infections, and antimicrobial resistances. Please help me welcome Dr. Mark Rupp.
Thank you. And I'll go ahead and launch into my presentation. I do have to obviously disclose potential conflicts of interest. And Teleflex is sponsoring the program, obviously, this afternoon. My goal, however, is to give you a balanced and evidence-based presentation, and I hope I achieve that goal. My objectives for the presentation today is that at the end of the presentation, I hope that you'll recognize the significance of catheter-related bloodstream infection and understand that it's really our understanding of the pathogenesis of these infections that allows us to formulate preventative techniques. I hope that you'll be able to describe evidence-based measures to prevent CRBSI by limiting both intraluminal as well as extraluminal catheter contamination, and that you'll be able to introduce some of these technologic innovations into your own institutions, or at least feel much more comfortable discussing them. So the first topic I want to address is that of the clinical significance of central line associated BSI or catheter-related BSI, and for the most part, people use those terms synonymously. So I think all of us who have been working in this field actually should give each other a good pat on the back, because the evidence suggests that we've been able to limit the number of CLABSIs fairly dramatically. In the United States, between 2008 and 2014, there was a 50% reduction in CLABSI. And I know that there are plenty of publications from Canada that show a similar decrease in catheter-related bloodstream infections. Now, according to the CDC, in 2018, there were about 40,000 central line associated BSIs in the United States in our hospitals and our dialysis units. And the incidence differed from one unit to another depending upon the risk groups. And so it was highest in our burn units and our neonatal ICUs, and it was down to 0 in some of our general medical surgical ICUs. In 2018, it was about 20,000 CLABSIs were reported in almost 4,000 hospitals, reporting to the CDC National Healthcare Safety Network. But despite differing numbers on how many of these infections there are in various countries, nobody argues with the fact that these are immensely clinically significant, and that when a patient develops a catheter-related bloodstream infection, the mortality is 2 to 3-fold higher than if they hadn't developed that infection, and the attributable cost can be absolutely astronomical. Almost all estimates are in the tens of thousands of dollars per episode. So how do these infections go about getting started, and what is the pathogenesis of the infections? Now, this is a very old figure from Dennis Mackey and Nassia Safdar, but I think it stands the test of time. And what it indicates is that many of the organisms that live on the skin, in certain instances, contract down along the external surface of the catheter, the extraluminal route of infection. But the longer that a catheter stays in place, the more likely it is that somebody messes up with their aseptic technique, and they contaminate the hubs or the catheter connectors, and then organisms track down along the intraluminal or internal surface of the catheter. Now, although we talk about it a lot, rarely do catheters get seeded from a hematogenous route, so an infection at another site that gets into the bloodstream and then seeds the catheter. And rarely, because of our good industrial practices and quality control, do we infuse contaminated fluids into the catheters. Now, once the organisms gain access to either the internal or the external surface of the catheter, they quickly adhere and they proliferate and they start to cement themselves down to the surface of the catheter and coat themselves in biofilm. And you can see an experimentally infected catheter that we did in our lab a few years back, that after 24 hours, you can see that this organism has been able to proliferate and is now 2 or 3 layers deep and starting to be covered by this polysaccharide, exopolysaccharide that we call slime or biofilm, goes by a number of names. And this whole issue of biofilms is something that has evolved fairly dramatically over the last couple of decades, where we've gained lots and lots of knowledge about biofilms and the importance that they play in the pathogenesis of these infections. But quite frankly, we still have an awful lot to learn. Now, this slide, both of these slides from Bill Costerton at Montana State University, show a fairly complex life cycle for biofilms, where initially you just get one or just a few organisms that are able to gain access to a catheter and attach to the catheter based upon non-specific forces such as polarity and hydrophobicity and charge. They then go about adhering and proliferating, having very intricate architecture. They mature, and then they go through a dispersion phase in which the organisms sense things in the environment. They may turn off their adhesins and then go free-floating into the environment to cause infections at other sites. And we've also learned that these biofilms are really complex, not only architecturally complex structures, but they're complex communities of organisms, and that these organisms are able to communicate with one another. They may release pheromones that essentially talk to one another. We know it's a very important environment for the exchange of genetic material and for the evolution of antibiotic resistance. So we're learning a lot, but we have a lot to go yet with regard to our understanding of biofilms. But putting that aside, how do we go about preventing these infections? And first, we're going to talk about what we should do in the pre-catheter insertion time period, as well as in the pericatheter insertion time period. And the first thing we want to do is make sure that the people who are inserting catheters and deciding who gets a catheter to really be educated about that. They need to be educated about their different kinds of catheter choices, and they clearly need to be competent in insertion. We need to make sure that the staffing and personnel is adequate to take care of these patients in our units. And then when a person inserts a catheter, they should be really using a bundle approach where they're using the maximal sterile barrier precautions, they're prepping the skin with chlorhexidine whenever possible, and they're having all of it driven by a checklist. So let's look a little bit about the importance of education. And although I know this is an old study, I think that it demonstrates that sometimes even relatively simple, superficial educational programs can make a big difference. This was a study that Craig Coopersmith performed, where he introduced a 10-page self-study module for ICU nurses. The education was required. They had to go in and pace themselves through this self-study module. And by doing that, they were able to decrease their pre-education period with an infection rate of 10.8 per thousand days down to 3.7. Now, this, again, was done some time ago, and none of us would be very pleased with these kinds of catheter rates of infection. But nonetheless, at that time showed fairly dramatically, as you can see in this graph, where the introduction of the education period was associated with a fairly precipitous drop and noticeable drop in the rate of infection. Again, just demonstrating the importance of educational efforts to really underpin all of our other efforts in the care of these patients. Now, as I mentioned, prior to inserting a catheter, a clinician should really go through a thought process of what type of patient they're seeing and what type of catheter that patient requires. Now, this is an algorithm that we use in our own medical center. It's been published, and you're free to download this and use it if you find it useful. But it really walks our providers through carefully the decision-making process of what kind of catheter they should be choosing for their patient. And I'm not going to go through this in detail. I know it's very small, but the bottom line is it walks people through, does their patient potentially just need a peripheral IV? Do they need a midline catheter? Would a PIC be better than other forms of central venous catheterization? If it's going to be a central venous catheter, maybe a tunneled catheter or a port would be more important. And so it kind of, again, goes through that process of what sort of fluids are you going to be infusing through the catheter, what kind of medications, how long is that catheter going to need to be in place, and then helps our providers make a more intelligent decision about what sort of catheters they really want for their patient. Now, as I mentioned previously, it's really important that we staff our units appropriately. And I don't think this actually gets enough emphasis. And that's because it's kind of hard to know. But, you know, what we do know about this is if we cut corners too much and we stretch nurses too far, that they start to get sloppy just by necessity. They're too busy and they're taking care of too many people. And the things that suffer are our patients. And one of the ways that they suffer is we get an increased infection rate. Now, this is a study that Scott Fridkin published some years ago, but what it shows is the nurse to patient ratio in this unit, or the patient to nurse ratio. And what you can see is that when it's about 1-to-1, the infection rate is at a stable, reasonably low rate. And then when the patient numbers go up, but the nurses' numbers don't go up with them and the ratio increases, they started seeing an excess number of CLABSIs. Now, again, this is kind of difficult because the number of nurses that you need for a particular group of patients is really driven by the acuity of those patients and the tasks that those nurses have to do, how many other professionals are working with them to try to extend those nurses. All those things come into play. But the bottom line is we have to have enough of these highly skilled, well-educated people taking care of our patients, or our patients suffer. And then when somebody does insert a catheter, again, they need to be using really a bundle approach using maximal sterile barrier precautions, which is shown in this slide. And so what I mean by that is the person inserting that central venous catheter needs to be wearing a cap, a mask, a sterile gown, long sleeve gown, and sterile gloves, as well as a head to toe sheet that completely covers their patient. They need to be using chlorhexidine to prep the skin, and then they should be getting those catheters out just as quickly as they possibly can when somebody doesn't need a central venous catheter. And this works. This was one of the landmark studies that Peter Provenost and his crew out of Hopkins performed. This was known as the Keystone Project, and it was performed in Michigan in over 100 ICUs. And they did exactly what we just talked about, used hand hygiene, full sterile barrier precautions, chlorhexidine. They avoided the femoral site when they could. They removed the catheters as quickly as possible, driven by a daily goal sheet. And what they were able to achieve in this study is a decrease in their rate of infections from about 7.5 per 1,000 days down to about 1.5 per 1,000 days. And then this has been replicated really in all kinds of different patient populations throughout the world. And this is just a follow-up study on the Keystone Project where they showed in those hospitals, again, falling infection rate as they introduced their intervention. But the important thing that I want to note is that after over 3 years of follow-up, they were able to maintain that decrease in infection, and in fact, get it even a little bit lower, down to about 1 infection per 1,000 catheter days. Now, these studies oftentimes come under some degree of scrutiny and some degree of criticism, because oftentimes they're not randomized, prospective, controlled trials. Instead, it's more make a change and then see what happens, and then attribute the results to that change. Some people have related that, we don't really know what components of the bundle are most important. So if somebody didn't wear a cap or they didn't wear a mask, would that make a big difference? We really, probably not, but we really don't know. What's the compliance level with those changes? Are people just cost shifting? So in other words, with all of the scrutiny and pressure that's been placed upon hospitals to get their rates of catheter-related BSI down to as low as possible, there is some concern that we're just simply cost shifting. So in other words, instead of attributing a bloodstream infection to a catheter, now we attribute it to some other source. And so we should really also be looking at total bloodstream infections in order to make sure that we're not just cost shifting. And then what's the use of technology in some of these studies is completely undescribed. And so are people using coated catheters? Are they using chlorhexidine impregnated dressings and other types of innovations? So next, what I want to talk about is, after the catheter has been inserted, how do we go about caring for that patient and caring for that catheter site so that we can minimize the risk of infection? Well, we want to perform good hand hygiene before manipulating the central venous catheter. We want to maintain clean and intact dressings, and some people have started using chlorhexidine impregnated dressings, and we'll talk a little bit about that later. You should scrub the hub every single time that the catheter is accessed. And again, some people are starting to use passive port protectors to take a little bit of that human factor out of it. We want to use closed IV systems. That's not important in North America, but some places in the world, they still continue to use open systems. We want to bathe our patients with chlorhexidine, and we want to remove the central venous catheter just as soon as possible. Now, how about technologic innovations? And one of my favorite infection control professors of all time is Bob Weinstein. And Bob is quoted as saying, if you can choose between education and influencing human behavior or the introduction of a gizmo, choose the gizmo every time. And I think what Bob was getting at here is that it's hard to get people to change their behavior. It's hard to get them educated. And therefore, if you can remove some of those human factors out by introducing a technologic innovation, many times that's the easiest and fastest and best approach. Now, having said that, it's impossible to make anything foolproof because fools are so ingenious. And what I mean by this is that no matter what type of technologic innovation you're using, if you're not using it correctly, it can be overwhelmed. So if you're using a coated catheter or a dressing or a cap, and you're having people with total disregard for their insertion technique and they aren't paying attention to how they're caring for a catheter, you can overwhelm that protective mechanism. And so you really have to combine these two together. You have to put in the education and do the hard work around trying to get people to change their behavior, but you can supplement that with innovations that makes it easier for people to prevent these infections. So let's talk about some of these innovations, and I want to spend most of my time talking about coated catheters. There's a number of coatings that are available on the market. The most widely penetrated into the market is the chlorhexidine silver sulfadiazine catheter or the minocycline rifampin coated catheter. Now, there's a number of others that are on the market, but they have enjoyed much less market penetrance, and they don't seem to work as well as those two those two coatings that are at the top of this slide. Now, the way these different compounds work is that some of them are antiseptics and some of them are antibiotics. Now, chlorhexidine is an antiseptic. It's been around for decades. It's used in all kinds of applications. It works via a very non-specific manner. It's a cationic polyguanide disinfectant that disrupts cell membranes, very non-specific. Likewise, silver is a disinfectant that deactivates enzymes and inhibits membrane transport. Again, a fairly broad, non-specific sort of interaction. Now, sulfadiazine is an antibiotic, and it inhibits the folate metabolism in organisms. And rifampin and minocycline are likewise both antibiotics. Rifampin inhibits the DNA-dependent RNA polymerase, and minocycline is a tetracycline class antibiotic that inhibits protein synthesis. Now, these different kinds of antiseptics or antibiotics have different spectrums of activity against different organisms. And that's what we're going to look at next. So this is a series of slides that look at in vitro studies in which the zone of inhibition around a catheter segment is measured over time. And so the first organism we want to look at is a common cause of central line-associated bloodstream infections, Staphylococcus epidermidis. You could substitute Staphylococcus aureus here if you wanted. And what this slide shows is that minocycline rifampin, so here's the catheter segment, and then here's the zone of inhibition on this auger plate that has the staphylococci. And you can see that minocycline rifampin has very good activity against staphylococci, and there's a very large zone of inhibition. Likewise, chlorhexidine silver sulfadiazine has a large zone of inhibition. And then the silver carbon platinum catheter has a smaller zone of inhibition, and the control catheter obviously has no inhibitory activity, and the organisms grow right up to the edge of that catheter. And then you can look at these effects over a period of 7 days, and you can see that the silver carbon platinum catheter dies off fairly quickly. The chlorhexidine catheter and the minocycline rifampin coated catheter are pretty well preserved out to at least a week. Now, the story around Pseudomonas aeruginosa is a little bit different. And again, you can see the control catheter with no zone of inhibition. The minocycline rifampin coated catheter really has very little, if any, activity against Pseudomonas. And you can see the organisms growing right up to the catheter, an almost minuscule zone of inhibition around the silver carbon platinum, and a relatively well-preserved zone of inhibition around chlorhexidine and silver sulfadiazine. And then you can see how, again, this is held out to at least a week with the chlorhexidine silver sulfadiazine catheter. The others are extinguished quite quickly. And then another organism that we seem to be having increasing problems with are yeast infections, Candida albicans and non-albicans Candida. You can see the control catheter, again, no zone of inhibition, silver sulfadiazine chlorhexidine with a pretty good zone of inhibition, minocycline rifampin and silver carbon platinum with very little, if any, inhibition. And you can see, again, how it carries out for a week and then extinguished very, very quickly for the silver carbon platinum and the minocycline rifampin without really much activity. Now, another area that we're trying to look at the effect of these coatings is in biofilm, the adherence of organisms, the ability to elaborate biofilm. And that's a little bit of that data is shown in this slide, in which they used flow cell technology, in which they took a catheter segment. They tried to mimic vascular flow through the catheter with the flow cells. And what you can see is in the uncoated catheter, there's lots of green fluorescence. And so what they did with these experiments is they used Staph aureus that they genetically engineered to have green fluorescent protein elaborated when it grew. And then you can catch that by looking at a luminometer and catching the fluorescence. It's really pretty cool stuff. But you can see that in this uncoated catheter, there's lots of green, meaning that there's lots of Staph aureus that has been able to adhere and to proliferate and to cause biofilm over the 24-hour study period. You can see here in the chlorhexidine silver sulfadiazine PIC catheter that there really is no green fluorescence. There's no organisms on this catheter. It was very effective in preventing adherence and biofilm formation. And then, kind of interesting, you can see the fluorescence increase on the uncoated catheter until it gets out to about 16 hours or so. And then you can actually see a little bit of decrease. What we think is going on here at the end of the 24-hour cycle, and you can kind of make that out with these big holes in the biofilm, is that the biofilm actually grows up large enough. It then either gets sheared off or it switches off its adhesins and floats in that last phase that we call the dispersion phase, so that those organisms then get off into the bloodstream and can potentially wreak havoc as they go and they seed other sites. So really kind of interesting technology to look at the dynamic process of organisms adhering and elaborating biofilm. And again, shows very nicely on the chlorhexidine silver sulfadiazine coated PICCs, the PIC catheters, that they're very, very effective. There's also some questions about the duration of the activity of some of these coatings. This is some information from in vitro passaging studies showing that the first generation catheters lose their activity fairly steeply, and by a couple weeks have minimal activity, whereas the second generation catheters, which are coated with about 3 times more chlorhexidine than the first generation catheters, and both on the inside and the outside of the catheter, you can see that level of protection is preserved out to at least 4 to 5 weeks. These are some experiments that we did in our own hospital where when the catheters were removed from patients, we went and tested them in an auger plate experiment. And you can see that the zone of inhibition is really pretty well preserved out, even with a few patients that went out to 6 or 7 weeks of indwelling catheterization. Now, another question that is sometimes asked is whether catheter colonization can be used as a surrogate marker for bloodstream infection. And I think this becomes more important as we have decreased the number of CLABSIs. It becomes increasingly hard to demonstrate a decrease in CLABSI as your endpoint. Not that that isn't what we're striving for, but it just drives the size of the studies to an almost unmanageable level. And therefore, the question is, can we use a surrogate marker to really predict whether a coating is going to be effective in preventing central line-associated bloodstream infection? And the answer, I think, is yes. So this was a study that was done a number of years ago, or a paper that was published, which correlated the CRBSI rate with the incidence of catheter colonization in about 30 different studies. And then they passed a trend line through it and did some statistical analysis. And what you can see is that the relationship is actually quite striking. That the higher the level of catheter colonization, the higher is the rate of CRBSI. So the converse is also true. The more colonization that you prevent with a coated catheter, the less CRBSI you would expect to see. And this is a strikingly statistically significant correlation. And then another question that people continue to ask is, do these coatings work? And if so, how much? Here's a meta-analysis that was done a number of years ago that compared the rate of bloodstream infection with silver sulfadiazine chlorhexidine coated catheters. And here's the number of studies that looked at the first generation catheter. I think this is kind of for historical interest only, because I don't know that you can even get a first generation catheter anymore. But what you can see is that it prevented about, a little over 30% of the infections. So the odds ratio of 0.68. Now, the second generation catheter is a little bit more effective and prevents a little over 50% of the infections in these studies. And then the minocycline rifampin coated catheters prevented about 70% of the infections. Now, some people, look at this meta-analysis and they say, okay, well, the minocycline rifampin coated catheter in these studies prevented 70% of the infections as opposed to 50% of the second generation catheters. Therefore, it's obviously a better catheter. What I would caution you is that, none of these studies were head-to-head comparisons. And it's really always dangerous to make those extrapolations without more direct data. And what I would point out to you in this regard is that the rate of infection in the control catheters in these studies was 5.9%. And then in the second generation catheter studies that I just pointed out to you, the rate of infection in the control catheters was 2.3%. And in the control catheters in the first generation studies was 4.2%. But in any case, again, a rate of baseline infection of 2.3% compared to almost 6% indicates to me that, there were some differences in the patient populations and in the routine practices that were being used in those studies. And therefore, I think it's a little bit dangerous to make a statement of one catheter working better than the other. In my mind, both of the catheters seem to work fairly well, and either one of those coatings is highly effective. And then I think this was brought out again in a more recent meta-analysis looking at 25 randomized controlled trials, comparing the chlorhexidine silver sulfadiazine catheter with uncoated standard catheters, with the antibiotic rifampin minocycline coated catheters, or the Allergon Vantex silver catheter. And what you can see is that most of the data is actually with the chlorhexidine versus standard catheters. There's 12 studies in that group. There's only one study between the antibiotic-coated catheters and the silver sulfadiazine-coated catheters, chlorhexidine silver sulfadiazine, and that was actually a first-generation catheter. And so you can see there's still some gaps in these comparative studies. But when you look at all the data, what you can see is that in the chlorhexidine silver sulfadiazine coated catheter, the odds ratio is about 0.64, so about 35% prevented infections. With the rifampin minocycline, about 50%, and with the other catheter, you're preventing about 30%. Another question that's asked is, are the coatings on peripherally inserted central catheters, PICCs, effective? And this is a meta-analysis looking at that body of data. It's not as extensive, but in looking at almost 1,500 patients, the CLABSI odds ratio in the PICC-coated catheters was almost 80% less than in the uncoated catheters. And the infection rate dropped between 2.4 per thousand PICC days down to 0.26 per thousand PICC days. You can see here are the peer-reviewed articles. Here's only the abstract articles. If you look at either one of those, they're just nearly the same. And when they looked at the difference between the antibiotic-coated versus the antiseptic-coated catheters, they really didn't see any difference between those two coatings. Another question that sometimes is asked is, will the antibiotic-coated catheters lead to antibiotic resistance? And what about the antiseptic-coated catheters? There's not a huge amount of data on this topic that I'm able to find. But the data that is out there is actually fairly reassuring. So this is one in vivo and in vitro study in which they passaged catheters, and they looked at catheters in a rat model. And what they found with looking at two different organisms, Staph epidermidis and E. coli, and if you just skip to the conclusion, it says that antiseptic and antibiotic catheters exhibited similar efficacy. However, when challenged with a rifampin-resistant strain, which sometimes does occur, the antibiotic catheter appeared to be more susceptible to colonization than the antiseptic device. And then here's another similar study that's all done in vitro, where they looked at a broader number of organisms. And what their conclusion was that their data suggested that exposure of gram-positive cocci to either rifampin or minocycline can lead to development of resistance, and that's fairly well known. Rifampin resistance, develops quite quickly when it's subjected as an agent alone. But what they also go on to say is that exposure of the bacteria to these antibiotics in combination does not directly lead to resistance, and they conclude that we need some more clinical data. Well, here's the best clinical data that we have with regard to the rifampin minocycline-coated catheter. This comes out of Sam Rad's hospital down at MD Anderson, where they looked at almost 10,000 central venous catheters, almost 500,000 central venous catheter days. They saw their CLABSI rate decrease from 8.3 down to 1.2 over the course of their observations, and they did not see the emergence of resistance. And then here shows the various kinds of things that went on in their hospital. So their baseline rate of infection was quite high, 8.3. They introduced the rifampin minocycline-coated catheter. They were able to drop their infection rate down to about 2 to 3 per 1,000 days. They then stopped using the antibiotic-coated catheter and just relied upon the practice changes. And you can see that their infection rate went back up. And then when they used both the antibiotic-coated catheter as well as the practice changes, the bundle approach that we talked about, they were able to get their infection rate down to a very low 1.2 per 1,000 days. So I think, again, a good, strong message that combining both practice measures as well as technologic innovations is really the way to proceed, and you can get your rate of infection down to a relatively low rate. What I meant to transmit with this slide is that, we don't stop at this point. We continue to seek better coatings for catheters. And you can see some of those different coatings on this slide. There's just an awful lot of things that are continuing to be investigated. I know our sponsor is actually looking at alexidine, which is a chlorhexidine-like disinfectant, but it has very minimal allergic reaction properties. But you can see that there's just a whole host of different things that people are looking at, trying to build even a more effective catheter. What I would say is, unfortunately, or maybe fortunately, it's going to be harder to study these coatings because our rate of infection at baseline is pretty low now. So demonstrating a significant decrease in catheter-related bloodstream infections becomes increasingly more expensive to do. But again, if we look at catheter colonization, that may be a more convenient surrogate marker for these types of studies. Now next, what I want to talk about, in addition to coated catheters, we have a number of other technologic innovations that I think are also very useful. One of these would be chlorhexidine impregnated catheters. I mean, not catheters, but dressings. And there's two of these that are out there on the market. There's a gel pad dressing, and there is a sponge dressing. The gel pad, as you can see, is clear. You can examine the insertion site. The sponge dressing comes as kind of a separate item, so you can use it with other dressing types. Both of these work very, very well. And so Dr. Timsit out of France has done some beautiful studies in their ICU system there, and has found that either of these work almost exactly the same in decreasing bloodstream infections down to a very low rate, particularly when used with the bundled approach of catheter insertion and care. Now, this slide is meant to show that catheter hub colonization can occur, and it can be relatively stubborn to get rid of when you're trying to scrub the hub. So here's a catheter hub that's coated with a ultraviolet tagged marking substance. And you can see if you scrub for 5 seconds or 10 seconds, all the way out to 15 seconds that you really need to do in order to remove that contamination. Now, this obviously is not a clinical study, and I'm not meaning to imply that it is, but it does show that, catheter hubs can become contaminated, and you have to work pretty hard to get rid of that contamination. And then I would also point out that these connector valves that can get contaminated, the hubs that can get contaminated, are very different in their manufacture. And one of the differences in the displacement, so you can have negative, neutral, or positive displacement. There's also differences in the amount of dead space. The flow through these catheters can sometimes be quite turbulent, or it can be fairly laminar. Some of them are clear, some of them are opaque. There's just lots and lots of differences in these mechanical valves, some of which have been associated with increases in infections. And I guess my advice to you would be, take a look at that information very carefully before you change your type of connector, and try to make sure that it's a simple connector that can be readily cleaned when you make a change in your type of connector. Now, because the scrubbing of the hubs is somewhat difficult, some places have turned towards the use of these passive port protectors. You can see one of them here that has a little alcohol sponge in it. So when it's on place, it continuously bathes the catheter hub with alcohol and keeps it disinfected. Now, just a few extraneous questions I want to address as we kind of end out the presentation. One of which is, what's the influence of the COVID-19 pandemic on CLABSIs? And we really don't know the answer to that right now, but the information that is available seems to indicate that patients with COVID do have a fairly high rate of CLABSI rate of infection. Here is some data from St. Louis, in which in 2 of their hospitals there, they found a really precipitous increase, hundreds of percent, in their CLABSI rate in those 2 hospitals, 3.79 and 5.8 per 1,000 catheter days. And the hypothesis for this is, number one, these patients are pretty sick and they need central venous catheters. They stay in the hospital a long time, and their central venous catheters stay in for quite some time. There tends to be an avoidance of those patients, so maybe the catheter sites are not being cared for as rigorously as a patient without COVID. And then because we've had to put so much of our prevention activities, infection prevention activities, directed towards COVID in recent months, we've sort of neglected some of the garden variety infections that we've been trying to prevent for a long time. And unfortunately, CLABSI may be up in those patient groups. This is some information from Italy, which showed a 12.9% incidence rate for CLABSI. And then likewise, in a hospital in Denmark, they found a 5.3% rate of infection. What about peripheral IVs? We've spent the whole time talking about central venous catheters, but peripheral IVs are likewise important, and I think people are starting to understand that they're actually quite important. We use hundreds of millions of these in our practices in the United States and in Canada. The rate of infection of those catheters is relatively low, but when you multiply it by the hundreds of millions of these that we use, it actually results in a very large number of patients experiencing bacteremia. Here's an old study that Dennis Mackey did, a large systematic review. Essentially, he found that the rate of infection in the higher quality studies was about 0.5 infections per 1,000 device days. However, if you extrapolate that out again to the hundreds of millions of devices that are used, he estimated almost 150,000 episodes of bloodstream infection in the US due to peripheral IVs. Len Mermel has done a little bit more recent look at this, and he found a rate of infection of 0.18%, 85,000 peripheral IVs, and that they were responsible for 23% of the catheter-related bloodstream infections at their institution during the course of the study. So again, a pretty impactful thing, and we need to be, I think, showing more respect for peripheral IVs than we currently do. What about midline catheters? I know a lot of institutions, because of the scrutiny and the pressure that's put to reduce central line related infections, have turned towards midlines because they're not regarded as central lines. Here's one study to show that the rate of infection in midlines may be higher than we've suspected in the past. This was a comparison between 165 central line days versus 25,000 midline days in 5 hospitals. They found that there were 23 midline associated infections with a 0.88 per 1,000 midline days. A substantially increased number of CLABSIs, but the rate of infection was nearly the same, 1.1 per 1,000 days versus 0.88, and was not a statistically significant difference. So, I think that midlines obviously can cause midline-associated bacteremias, and there also is some data out there to suggest that they're more likely to be associated with thrombosis. So, turning to midlines in an effort to get rid of central line associated BSIs may be kind of a shell game where we're just, shifting things around a little bit. So midlines, I think, need to be treated very, very carefully, just like we would central venous catheters. And then I'll end with arterial catheters. For whatever reason, there's an awful lot of critical care docs that don't think arterial catheters are at risk for infection. We know that is not the case. Here's a little bit of that data where they are associated with about the same rate of infection as central venous catheters. We use a lot of these in our critical care units. In a survey that was done a number of years ago, only 44% of institutions followed the CDC recommendations for arterial catheter insertions. And my strong feeling is that arterial catheters should be inserted and cared for very carefully, just like we do with central venous catheters. And then I'll end with this quote that I think is kind of funny, but also very true. This came from the Secretary of Defense in the United States a number of years ago, and Bob Rumsfeld said, "There are known knowns. These are things that we know that we know. There are known unknowns. That is to say, there are things that we know we don't know. But there are also unknown unknowns. There are things we don't know that we don't know." And I think this is very true, and we need to keep it in mind that, even though we do have a fair amount of knowledge about central line-associated bloodstream infections, there's still a lot more to learn, and we need to continue to work hard on learning new things and better ways of preventing these infections. And then I've added my own corollary to this, and it says there are things that we think we know, but we're wrong. And we also need to keep that in mind. We keep an open mind, be able to change as data accrues, and that we're, as we learn more, we need to adjust our thinking and our practices. So with that, I'll close, and I think we have some time for questions. And again, I'm very, very pleased to be with you today, and am honored to do so. And with that, I'll end the slideshow and hopefully go back to just a question and answer period if we have any.
Great. Thank you, Dr. Rupp. That was a great session. I have a couple questions. Can you hear me okay?
Yes, I can. Thank you.
Okay. With the incidence of BSI related to peripheral IVs, should the port protector technologies be also used on all vascular access devices when a patient has a central line in place?
Yeah, that's a great question, Amy, and we've addressed that in our own institution. We do use the port protectors on peripheral IVs that are lying fallow. So when you see patients with a HEP lock or something like that in place, we are using the port protectors. However, we've tried to limit it to places where we think those peripheral IVs are going to be in place for a period of time. So in other words, if we have a person coming in for a procedure, like they're undergoing endoscopy, for instance, that catheter is going to be in place for 2 or 3 hours, and then that's it. We're not using them in those areas. But when we see patients in our hospitals, we are tending to try to use those and protect those peripheral IVs as well. The other thing that I would mention is that we really need to change our mindset around peripheral IVs. And it used to be that most institutions had policies where they automatically removed peripheral IVs after 72, sometimes 96 hours. Well, that I think has really changed with some of the studies that are coming out of Australia with Picard and others that have shown that, really if you're putting a peripheral IV in, you can kind of leave it in until you don't need it anymore or you start to see signs of inflammation. Now, I think that's okay, but that means we need to be really inserting peripheral IVs and caring for them carefully. So we should be using chlorhexidine to cleanse the site. We need to be using careful aseptic technique to insert the catheters. We need to be inspecting the site carefully and taking them out very quickly when there's signs of inflammation. And quite frankly, just to air some of the dirty laundry, sometimes I'm dismayed when I see people insert peripheral IVs with, a fair disdain for aseptic practices. We continue to see people who really don't treat that as a, catheter in somebody's vascular space, and they need to be careful with them.
Yeah, I think you make a great point, because most patients don't ever just have a central line. They always have, for potentially a period of time or extended period of time, also other access points that could potentially seed and infect. So thank you for that. I have another question.
Yeah,
how about go ahead.
No, I was going to just make a quip that, I think there must be some sort of legislation that says a person cannot be in a hospital without a peripheral IV. It's kind of a shame, and I'll see people who really don't need an IV, but right up until the moment they're discharged, they're just going to keep it in. That's oftentimes the last thing that happens is you pull the IV and you discharge somebody, even though they haven't had anything going through that IV, sometimes for days, and it's a real shame.
Yeah, I think as infection rates get smaller, like you said, and we're going to have to get more meticulous, we may see some of those changes in policy in hospitals. How about in different regions of the world, we're implementing protected technologies, and in different regions of the world, there's higher sensitivities and or allergies. Can you talk a little bit about the risk benefit of having a protected catheter?
Sure. And so, that's a very astute question. Where most people have concerns about this is in persons of Japanese ancestry with chlorhexidine allergy. And, that's been pretty well documented that is of some concern in that patient population. I don't think that is, really been seen in other types of ethnic groups. It probably occurs at a very low rate in some other groups, but it certainly is exceedingly unusual. Likewise, you can see sometimes allergic reactions to some of the other coatings, but these have been used in really millions and millions of patients now with very, very low rates of complications or allergic reaction. And for the most part, it's something that people need to be aware of, and you need to know what kind of catheter you're using in your institution. And if you see somebody with an unexplained reaction, it is something that should go through your mind. Maybe I'm seeing an allergic reaction to the catheter coating, but for the most part, it's a very, very rare phenomenon. The other thing I would point out that your company is probably going to grit its teeth, because I know it's not FDA approved, but there is work with the alexidine coating, and that's a type of antiseptic chlorhexidine-like compound that is very much less allergenic, and so that may be an improvement on that technology that comes out at some point.
Yes. I think always the ability to innovate and keep patients at the center of what we do. I think we've strived for that over time. So as there's a new need in the market or an identified gap, as Teleflex vascular, we're always seeking that. So thank you for that. Just one last question for you. I don't believe there's a silver bullet. So what would some of those recommendations be for hospitals in Canada that may be struggling to reduce their risk of infection or bring their rates down? What are some things that you would suggest to them as we close out this session?
Yeah, again, I think that people need to look at their data carefully and to put measures into place. Particularly some of the easier bundle approach. So making sure that they're using full sterile barrier precautions, scrubbing the skin with chlorhexidine, trying to get rates down. But then, if those rates are a little stubborn, which oftentimes they are, then it's time to, not beat people up too much, and probably would be cost effective to go with one of these technologic innovations. Again, I think coated catheters are a great way to go because they address both the internal and external surfaces of the catheter, addressing both routes of inoculation and pathogenesis. But likewise, there's strong data for the chlorhexidine impregnated dressings. There's not nearly as much data with the pore protectors, but there's some studies that are coming along with that. So there are a number of choices that people can make. And by doing that, you really are able to get an infection rate somewhat south of about 1 per 1,000 days. I agree with you. I don't think we're going to eliminate these. I don't think there's a silver bullet, but we need to continue to push them down to a level that is very low. And so if you're north of that number, then I think you need to continue to work on it. At some point, people do need to think about, is there a point of diminishing returns? And if you're at a rate of infection that's quite low, and when I say quite low, I'm saying are you really down to 0.5 per 1,000 days, and getting it lower than that, you may be better taking that same investment and trying to prevent falls or medication errors or CAUTIs or ventilator-associated pneumonia or something like that, from a societal viewpoint of trying to think, what's our best return on investment. Now, I know that's probably not a popular view in this presentation, where we want to push catheter-related bloodstream infections, down to zero, but zero is probably not going to happen. And we just need to accept a low level where we've done most of these things that we've talked about to try to get that infection rate as low as we can get.
Yeah, I agree with putting the resources where it best impacts the patient. And bundling's been around since 2011. Technology's been around for 25 years. We have multiple facets coming to help clinicians. I think one of the other things is understanding where the infections are coming from and understanding the sources. because that also helps these infection preventionists and or clinicians make better decisions. Would you agree on that?
Yeah, and I think that people can look at their data, look at the causative organisms, and that may give them, a real clue as to what they want to do next. So, in my presentation, we talked about, Candida infections or gram-negative rods or skin organisms. If you're not seeing a lot of those skin organisms, then you're probably doing a pretty good job with insertion and skin cleanliness and, having an intact dressing. If you're seeing lots of skin bugs, well, then it's time to go back and look at, okay, what are we doing to prep the skin, keep the skin clean, make sure the dressing is intact, those sorts of things. Because there's a little bit difference with regard to the different organisms that you see associated more maybe with hub colonization versus skin colonization, et cetera. So I completely agree with you. I think you have to look at your patient population. What's going to work in one unit may not be the same as another unit, and then you need to try to individualize a little bit between units and even between institutions, for sure.
Yep. I did get a question from the audience that says, why not reach zero? I think that we talk a lot about reaching zero, but getting there and then sustaining zero is quite a different feat. Do you have any comment on that?
Yeah, I do, Amy, and I think that if you're talking about zero CLABSIs, you're never going to get there, because the definition of a CLABSI, at least the ones that we use in the United States through the CDC and the NHSN, are just not precise enough. They're a surveillance definition, and they're going to detect a lot of things that are bacteremias that aren't necessarily due to CLABSIs. I can tell you, I review those every month at my institution, and I would bet that at least half of what we report to the CDC, in my heart, I know are not catheter-related bloodstream infections. And it's because of the definitional stuff. We're never going to get rid of that unless you change the definition, and then you lose some of the sensitivity. So I think that unless we get a lot smarter about this and how we define these infections, we'll never be at zero unless you're cheating. And if you're cheating, then it's easy. You just declare everything not due to a catheter, and then I could get to zero, but that's because I'm cheating.
Yeah. We actually see that in sort of the development of different units and the movement of patients to non-reportable areas, etc. But what about, would it be easier? You just mentioned something, and I promise this is my last question. Would it be easier if everything was reported? Because then we would be on a level playing.
Yeah, I've been a proponent for reporting both total bloodstream infections, nosocomial bloodstream infections, as well as CLABSIs. And so by doing that, you may be able to actually catch people with some of that cost shifting. Because if you push your CLABSIs down and you don't see your total bloodstream infections coming down as well, that all you've done is just, again, I just call it cost shifting. All you've done is said, oh, that's not due to a central line. Instead, it's due to the wound, or it's due to, the UTI, or, the skin soft tissue process, or whatever. You're just shifting it off to something else. So I do agree. I think part of the danger of doing that is that, people just game the system. And so in some places, you might see clinicians say, okay, well, let's just not do blood cultures. Instead, everybody who looks like they're septic, let's just treat them with broad spectrum antibiotics, not draw blood cultures. And, then we don't have any CLABSIs and we don't have any BSIs. Now, unfortunately, obviously, then you have poor antibiotic use and you have antibiotic resistance and all kinds of other problems. But you have to be really careful with how you craft these definitions and these reporting schemes, because sometimes you get unanticipated consequences of making those changes. So, overall, I think the effort to reduce central line associated bloodstream infections and report those publicly and incent hospitals has been good, but there are some downsides to it as well.
Yeah, and I know that this all doesn't apply to Canada because they may or may not have to report, may not follow under the same jurisdiction as what some of the NHSN requirements and such are. But again, I think the important thing is knowing your rate and doing your best to reduce it as much as you can institutionally. I just want to say thank you for today. This was a great webinar, and I hope that the audience from Critical Care Canada also enjoyed it. And I just want to thank Dr. Rupp for your wisdom and knowledge on this very important topic. So thank you.
Yep, thank you. It was a real pleasure to join the group.